Thank you, Maddie, and thank you all for joining after lunch. So for the next component of today's session, we're going to be doing the CEPAC votes on clinical effectiveness and value. And I just remind my colleagues on the voting panel that we have the clinical experts and the patient experts here in case there are questions. We invite kind of questions and public deliberation about what you're thinking about your vote. And then we also have the evidence lead and the health economics lead here for questions about their findings that might inform your vote. So I might, at this point, encourage my colleagues on the CEPAC voting panel to join the voting program. And just make sure everyone's here. Okay, I think everyone's here. So for the voting questions, it's important to sort of be explicit about the patient population and the comparators. The patient population for these questions are individuals who have advanced retinitis pigmentosa, referred to as RP, with severe vision loss. And then in all questions, there's not a new comparator. It's sort of usual care, which includes low vision aids, mobility training and support, and vision-related rehabilitation. And this is true for all the questions today. Okay, next slide. Okay, so the first question is the clinical comparative effectiveness question. And that is, so again, for patients with advanced retinitis pigmentosa, is the current evidence that you've seen today adequate to demonstrate that the net health benefit of sonperadagine is greater than that of usual care? And maybe, Anil, do you want to just summarize the evidence to get us started on deliberation?
Yeah, happy to. And there's a evidence summary accompanying the materials, and I can briefly go through those. So on page 6 is the description of the trial, including baseline characteristics. Page 7 is table 5 are the main results for the primary outcome of visual acuity, which both treatment groups were statistically significant improvements over the threshold of 0.3 compared to the sham. The change over time, as we discussed, is in figure 2. Individual participant responses is in figure 3 on page 8. And then the secondary outcomes, the main results are in table 6 and 8. And then there's an alternate way of thinking about response in table 7, 9 that are in our report, but we did not cover in the presentation. And then the composite responder analysis, which showed the sonperadagine group responded in greater numbers for 1, 2, and 3 different outcomes in composite. And then we have a individual participant data across all 3 outcomes on table 11. And it's important to note that when it says no improvement detected because of the floor and ceiling effects of both outcomes, we can't be certain that there was no improvement, just not detectable on the outcome measures that were available in the trial. And then the safety outcomes are on page 12. And our summary recommendation for the evidence rating was promising but inconclusive for the uncertainties that we discussed before.
That was super helpful. Thank you for summarizing. Does anyone on the voting panel have questions for the evidence team or for the clinical experts or patient experts? I know we discussed the P/I rating this morning. Megan, I think you have something to say. Go ahead.
Yes, just a quick question. In terms of, we're looking at the net benefit, and I appreciate the discussion we had about harms, and that there's some concern. Is there any evidence of harms caused by this?
In the short term, it was mostly mild to moderate eye adverse events. No major serious harms, deaths detected out to 100 weeks approximately. 5-year data is still pending And then from animal studies, we know that gene therapies like this, including this therapy, can leave the eye and can go to the contralateral eye that's not treated. And we do know from like Luxturna that it can go to other tissues like lymph nodes and liver, spleen. But whether that causes harm hasn't been demonstrated in other gene therapies of the eye or this one. And Dr. Mahajan, you have your hand raised. So
Yeah, I'll just speak to the harm. I think, this is a highly synthetic protein. So one of the biggest concerns was, would there be an inflammatory response to it? Because these are non-human proteins and probably one of the most synthetic protein ever put into a human. And in that regard, the inflammatory response was pretty typical for any other gene therapy, and minimal and well controlled. And unlike other eye clinical trials, these patients are blind to begin with. So unlike many of our eye trials where patients do have sight, the potential effective harm could be much worse. Whereas in this case, the vision is so low, it's hard to make it worse inside the eye. And then for external harm, really the evidence is just in this non-human primate, and does the gene appear there or not? And so in that case, it didn't show. You obviously can't predict so far, into the future, but pretty reasonable and better than I would have expected in terms of inflammation response.
So obviously there's a question of uncertainty here and sort of plausible mechanism. Does anyone on the CEPAC panel want to say? And you can kind of say what you think without committing to voting one way or the other, I'd say. But does anyone want to share their thinking about how to think through these issues, kind of in the spirit of public deliberation? Steve, I don't know if you were responding to me or you had something else to say, but please go ahead either way.
Thanks. Well, my thought process is that the magnitude of benefit isn't qualified here. So any degree of better than usual care would seem to require a yes vote, balancing safety as well. And just one other thing that comes to mind as I look at the question, sorry I didn't think of this earlier, but I think the comparator is usual care alone, because usual care was also delivered in the intervention group.
that is correct.
So yeah, and then the other thing to note, I'm not sure if this is pertinent or not, but just because this was a sham placebo control, is that the question is against usual care, not against placebo. It may have a slight difference because of, I'm not actually sure if this is true, but conceptually the sham placebo could have generated some of the inflammation that was reported as a harm in both groups. That's at least my sense. If anyone disagrees, I'd love them to speak up, but that is something to think about. Brian.
Yeah,
go ahead.
I'll play devil's advocate here a little bit and just say, I'm not sure we can say that it's better. I mean, obviously there's some very dramatic, if someone can't see and suddenly they can see some, that's a dramatic improvement, but it's 18 people in the treatment arm and a selected group of people to be in the study. And to generalize that to say that it's going to have an effect for the whole population, I think is a huge step. It's making a big assumption. And some of the people, not everyone did respond. Now, I know there's that floor and ceiling issue, so we may have missed some people who really did respond, but it was impossible to know because of the scales. And again, the manufacturer made up a couple of scales that haven't been validated. So although the science is amazing, and yes, if I went from no vision to some vision, I would think it was amazingly wonderful. So I'm not trying to be negative, because I think there's some real positives here. But I think we have to be careful about overgeneralizing from a very small population with some tests that aren't validated. So I'm just going to, again, playing devil's advocate that it may not be quite a slam dunk yes, as some may think.
Thank you so much, Brian. Dr. Lavelle, Tara?
Yeah, I'll just be really brief because I was going to say the exact same thing. So I just, want to acknowledge that, yeah, you know, this was a very small sample size. We don't know the selection bias. We don't know the overall characteristics of the total population with this disease. So to make very large population decisions based on 27 people, I have, yeah, reservations about. So put that out there.
Thank you. Yeah, I'll say, like, I acknowledge all the points. I would, you know, this is the devil's advocate to devil's advocate thing, I guess, a little bit, but I'd say that all those things are true. But it is also true that this was a randomized experiment. It was properly sham controlled. We always have questions about efficacy versus effectiveness. I guess maybe they're worse in a condition where there's a lot of heterogeneity by the genetic variant and there's such a tiny trial. But many of the questions about how something might work in the real world exist in any kind of randomized controlled trial. These are obviously very difficult issues to consider. Joe, I think you have something that you want to say too.
Yeah, it might be sort of aligned with what Tara and Brian were saying, but I think, you know, where I'm sort of caught up in the question is, you know, the adequacy of the evidence, not so much whether there was demonstrated benefit in this group, but is that adequate evidence to sort of convince that that's the long-term solution? I think that's where I'm just sort of sitting with the recognition that there's that level of uncertainty too around adequacy. Just want to say that out loud.
Yeah, no, it's a great point. And I think the word, I don't want to say it's purposely ambiguous, but it is up to each of us to sort of determine how to interpret the word adequate. I think it's a really good point. Megan, I think you want to say something. Go ahead.
Yeah, just responding to those comments, I think we need to remember that it's a rare disease and we can't hold rare diseases to the standard that we would for a common disease where you would expect to see, you know, several hundred or 1,000 people in the trial. And then I also just want to clarify that we're not being asked to say that the entire population would benefit from this therapy, right? The generalizability question is whether kind of approximately the same results would happen in a larger population. So I also don't want to, again, hold this to a higher standard than we would for other less rare diseases.
Yeah, no, I totally appreciate that thoughtful point that you're making. At least for what it's worth, my interpretation is sort of aligned with what you're saying, which is to say that I interpret this question as the net health benefit referencing the average net health benefit, that there's always the possibility, even if something works, that any specific individual might not benefit, even if the average in the population is increasing. I'd welcome any pushback about that interpretation, but at least my understanding is kind of aligned with what you just said. Rishi, go ahead.
No, I sort of, it's a great discussion, and I agree with all that your point, Jason and Megan, that rare disease can't run a big randomized trial of 1,000 people in this population like we can maybe in cardiology, which is where the numbers we're used to. And I think the generalizability thing, I have a question, or maybe I'll start with my comment. My comment is that the heterogeneity of treatment effect issue, I think everyone's saying this, is always true in any trial. It's true like in randomized trials of statins for cardiovascular risk. We just don't know. We just know that there's always going to be heterogeneity in response to treatment effects. And so we have to rely on average treatment effects generated from randomized trials to make decisions about whether it's a therapy that demonstrates benefit. And then my question actually is related to the generalizability point, which I think is an important one. Of course, it's tough to generalize, make statements about the generalizability of a small trial because it focuses on a rare disease. But is there anything about the enrollment criteria in this trial, I may have missed it, that makes us concerned that this was a highly, I know it's small, but that there was something about the selection or the enrollment criteria that makes us even more concerned about generalizability? Just wanted to build off that point.
Yeah, Rishi, that's
thanks for
a
the
good point. The clinical experts could answer, or
Maybe
Anil, yeah.
Yeah, I'll answer and I'll turn to our clinical experts who take care of these patients and do the real work. Nothing from the inclusion criteria. It's pretty broad because of the nature of optogenetic therapies not targeting the underlying condition. it's thought to be mutation agnostic, at least that's the theory. We don't yet know kind of what's the breakdown of the genetic mutations and the inheritance, and subgroup analyses are always fraught to draw any kind of conclusions, but especially in a group of 27. So even knowing that, I don't think we would know that, but whether it's generalizable to all of RP, hard to know like what was the makeup of like X-linked or autosomal dominant and whether those differed compared to the general population. But nothing specific in the trial itself that would have chosen any specific people other than the usual biases of who participates in trials. And I'll turn to Dr. Russell and Dr. Mahajan, who think about this much more.
Thanks, Daniel.
Dino, do you want to go first?
No, go ahead, Steve, please.
So my perspective on this would be, your observations are absolutely correct. That we don't know specifically what the frequencies. Well, first of all, there are over 300 genes that can cause retinitis pigmentosa or retinal degeneration. The proportion of those genes in the population is not uniform, meaning that there are some that are highly represented, some that are intermediately represented, and some that are not only rare, but extremely rare. So they're all rare, but they're, graded in terms of rarity. But the best study that I can think of is a study on 1,000 consecutive families that was evaluated here at the University of Iowa by one of our colleagues, Ed Stone, who demonstrated the distribution of mutations in identifiable families in a very large cohort. So it was 1,000 patients. So you're talking about your cardiology studies, there you go. But that was a natural history study. Then the question then is, in this study of 27 patients, do those mutations mirror the frequency of the mutations in the US population, which is admittedly could be biased, but it's the best distributional information we have? And the answer would be no. The most common mutation is ABCA4 for Stargardt's disease. And I believe there may have been one in this population, or maybe we don't even know specifically what the number were. But yeah, that is an issue. So if it is not an agnostic treatment, a gene agnostic treatment, then there may be issues related to the distribution effect on the population genetically. I'll stop there. Thanks.
Yeah, I'll just comment. I live in the world of orphan diseases, and by that standard, this is not a small trial. So so everyone keeps saying this is a small trial. This is actually a huge interventional trial in a patient population of RP that's been excluded from every other therapeutic trial. And I completely understand if you're not living in the world of orphan diseases, how it seems, quote, small, but I wouldn't say that it's small. I think the entry criteria were quite broad, and statistically, it's not possible, like Steve was saying, to determine was it an exact genetic match across. I think it's pretty good because it's a smorgasbord of mutations. And that there wasn't a criteria like that. So I think that bodes well. The real issue is the anatomy or the degeneration. And I think the positive signals that they saw that were discussed was that if they can catch a patient a little bit earlier, there's a chance that they may be seeing a bigger difference, and that the enrollment is actually biased against them because most of their patients were at this floor. And in the study that Steve led on the first FDA-approved human gene therapy, Luxturna, it was well known that if you were able to actually treat patients who were younger, where their retina was a little bit more intact, they were going to have a better response. So I think this is actually a big trial for RP, and that the population that was enrolled is probably biased against the therapy a little bit.
Yeah, I think the two of us on the CEPAC that are having to frame shift the most are the cardiologists, me and Rishi. I think this is a very different kind of space than what we're used to. David, I think you have something to say.
Yeah, I just wanted to talk about thinking about evidence in orphan and rare diseases. And people come down in different places on this, and you as a panel are welcome to think about this however you like. I will speak from my background in the EBM world, and when I used to teach this, which is to say, we don't grade on a curve. The evidence is the evidence. The fact that it's hard to get evidence in very rare diseases is completely true. And yet we still have the evidence we have, and we should make judgments about it. It doesn't make the evidence better that it's hard to do a trial in a given space. And it's also the case that you can have in tiny populations high quality evidence that answers a question. When we looked at a gene therapy for spinal muscular atrophy in an uncontrolled study in 12 patients, we gave that an A rating. So it's not that it's impossible to know these things, but it's both important to acknowledge that a study may be the best study you can get, but also be, from my point of view, objective about what the evidence tells you. I think personally that this evidence suggests, I'm pretty convinced that there's efficacy here. As you heard, I have some concerns about harms. I have some uncertainties around all of this, but I'm more convinced on efficacy than some of the people on the CEPAC listening. But the fact that it's hard to do a better trial doesn't increase my certainty about either the efficacy or the harms. So I would encourage people, as you're thinking about these things, not to grade on a curve.
Thank you so much, David. Don, you have a comment or question?
I just wanted to maybe confess a bias that I bring to this discussion as I've listened to the conversation thus far. I happen to be the parent of somebody who has a rare disease and who is a participant in a gene therapy trial. And in fact, she happens to be patient 3 in that trial, and the CF doc in the crowd will know which trial I'm talking about probably. And the results that she personally had in this initial trial were so remarkable. And what I have found remarkable is the effect that that one data point seems to have on where that whole study seems to be going. So it's so hard for me to walk away from the idea that even though this is a small study of a small group of people, it still does, because we're talking about a rare disease, produce adequate evidence to demonstrate that the net health benefit is there or greater than that of usual care. If any of you want to tell me that I should disqualify and just not vote because of my personal experience with this idea of gene therapy trials in the rare disease space, go ahead and suggest that. I don't think I have to, but I just wanted to put that out there.
No, Don, I mean, look, thank you so much for your perspective. You bring so much to our panel because of this life experience and perspective. I definitely don't think you should. I mean, you've just disclosed it. I don't think there's any reason to accuse at all. Others can speak up if they feel differently, but I don't think so at all. And thank you for your amazing perspective. You bring so much to this panel.
I just wanted to say, though, that it really does make it possible for me to understand why it isn't necessary that there be 1,000 patients in this trial.
Well, and that perspective brings so much to our group, so we're very appreciative. I know this has been like a masterclass in comparative effectiveness research in terms of all these issues. Does anyone want to say anything else, or maybe even state how they are thinking to vote before? We can also give our people an opportunity to say how they did vote after we vote, but I just want to make sure I don't rush this before we go ahead to move to vote. Okay, I'm not seeing anything else. So feel free to go ahead and vote in the system. And Maddie, correct me if I'm wrong, but I'm going to wait for 12, right? We have 12 people. I see 9 votes. Thank you. 11 votes. I think there's 2 left, or so 1 left, sorry. see 12 votes. Let's see the results. So 10 voted yes, saying that the current evidence is adequate to demonstrate that there's an health benefit of sonperadagine greater than that of usual care, and 2 voted no. And so I always hesitate to put people on the spot, but maybe for the 2 who voted no, does anyone want to speak up and say a bit how you voted, so we can get that information into the final report? You don't have to. It's up to you.
I can speak up. I voted no, and again, I think I would have felt better if there was more documentation of, you know, how this patient population was potentially representative of a broader population. Again, even knowing that that population is small, right? It's a small group with a rare disease, but I didn't have the evidence to have any to be able to make that comparison. And also just understanding the word adequate, I don't think that this is necessarily saying that it's not, that there's not evidence to say that there's a positive net health benefit. I just didn't feel like there was too much uncertainty around that, because I couldn't really estimate which direction that sampling bias would go based on the evidence I was given.
Yeah, no, I think these are the issues we're all struggling with, and we so much appreciate you sharing that perspective. I think we
I
all
also want to say that I think this is, you know, a group that really, you know, needs an effective treatment. So I struggle with all of that as well.
Yeah, that's absolutely correct. And so actually that comment right there is a great segue to the next question, which if you could bring it up. This is, you know, so what we do now is to sort of better inform any judgments of overall long-term value for money. We have some questions about benefits that are beyond health and special ethical priorities. And actually, the first question should be, and this is a Likert scale answer, is there is substantial unmet need despite currently available treatments. And actually, to begin this conversation, I'd love to hear, we have patients on the line. We'd love to hear your thoughts about this question before the panel deliberates and votes. You don't have to say anything, but I'd love to hear if you do want to.
Yeah, this is Todd Durham, if I can.
Yeah, absolutely. Go ahead.
Yeah, Todd Durham with the Foundation Fighting Blindness. I myself am not affected, but the panel heard earlier individuals in the RP community who are, and I would always defer to their voices over mine, but I have had the honor and privilege of working with many individuals with advanced RP, some of whom are on our staff here. There is significant unmet need in this particular stage of the disease. Although we heard from the patient representatives earlier, they're highly resilient and thriving. From all we can see today, from their comments, they're doing quite well. But as individuals progress through RP, they do adapt. Thankfully, they oftentimes struggle to say yes to a white cane. Many of them will describe that as a turning point in their new life with advanced RP, the moment that they said to themselves and others that I actually do need some assistance here. And then likewise, when individuals choose to adopt a guide dog, similarly, many people will say this was a new level of independence for me. Yet people with those assisted devices still struggle with daily things. Things that I observe among my colleagues. We have a work retreat, and you and I might orient ourselves to the bright spotlight up on the stage when we stand up to make a comment. If they have no light perception, they don't know whether to orient this way or this way. And that can cause a lot of embarrassment for them, even knowing that someone is at the table with them or not while they're having a conversation. Often we hear how embarrassed they were to realize that, Todd, I didn't actually realize that you left the table. So we train our staff to announce that you're leaving the table so that we can assist them. And even basic things that have to do with a sense of security in a room. We all sighted folks take it for granted that we could, in a power outage, navigate to the brightest corner of the room. Many of these folks with no light perception or very little light perception at all do not enjoy that sense of security, knowing where do I need to go if I need to leave the building. So even restoration of a slight bit of light sensitivity in advanced RP patients could make quite a bit of difference in how they navigate and feel in the world.
Thank you so much. That's so helpful. Does anyone else have anything they want to say, including from the panel, about how you? Oh, Dr. Mahana, here. Go ahead.
I just wanted to make a comment. The patients that we heard from today were really remarkable, quite resilient. I find a lot of RP patients seem to be the most intelligent and positive patients. But I did want to speak on behalf of a large segment of population of patients that I do have. And these are patients without adequate resources like we heard about. And at many stages in advanced degeneration, they're not able to work. They're left at home. They have to navigate the house by themselves, reaching for food and drink. They're knocking things over. The depression rate is higher because of the loss of vision and the isolation. And so that segment of the population can have quite a different experience when they don't have adequate resources. And so I'm heartened to hear, and in general, that manufacturers approaching these patients are trying to take into account accessibility of this kind of treatment, which could be quite life-altering when you don't have family members who can stay at home, who have to go to work to assist with different things.
Yeah, and I think it was, as we've heard today, there's probably differential effects of that on socioeconomic status as well. Vulnerable patients having an even harder time. Steve, go ahead.
Yeah, thanks.
Dr. Richards.
Oh,
Go ahead, Dr. Russell. All right, great. Dr. Richardson showed us a slide about the equal value life year shortfall information. That seems germane to this question. Wondering if maybe Dr. Wren or Dr. Richardson might want to just provide in context for those of us maybe who are approaching this empirically.
Yeah, so the proportional absolute shortfalls are a quantitative way of assessing unmet need. And I think they're most valuable in comparing to other conditions to provide context. And in this case, they, I have the slide up here. I don't think it's in your evidence summary, but it was in the slide deck. And so the absolute EVLY shortfall is 14.9, proportionally at 71%. And so this aligns with conditions like multiple sclerosis on an absolute basis. And so it is quite a high unmet need, mainly driven by the low quality of life that we see, as well as the age, the starting age of patients here.
no, it's so helpful to have a quantitative assessment of that as well. So thank you, Marina, for adding that. I would propose that we go ahead to vote unless anyone wants to say something or ask something. Seeing none, the voting question is open. I see 6 votes, 7, 8. 12 votes. Let's see the answers. Okay, we have there's substantial unmet need despite currently available treatments. Most of the group said strongly agree, with a minority saying agree, and then one person said strongly disagree, and I will refrain from putting that person on the spot. Let's move to the next question. So the next question is, again, a Likert scale question. This condition is of substantial relevance for people from a racial and ethnic group that has not been equitably served by the healthcare system. And again, there's a Likert response. I don't know if, maybe Anil, do you want to comment on this briefly in terms of any findings you came up with?
Yeah, in terms of risk factors of who gets illness and rate of progression, we don't think there's a racial ethnic component. But we definitely heard that there was a strong consideration for who could successfully adapt to living with advanced RP along socioeconomic lines. So as those fall across racial and ethnic groups in the US is certainly in consideration. This is limited financial means, less flexibility with taking time off work or school, having the necessary social support. You can think about digital literacy with using iPads and other readers. And we didn't have those voices necessarily, but we heard from representatives in foundations, as well as clinicians who talk about this, as well as Dr. Mahajan brought up.
Thank you. Does patients or clinical experts anything to add before we move to vote?
Todd Durham, if I could just state briefly something that is a particular example here. I know of two folks who support the foundation through their volunteer efforts. They're affected with advanced RP. An example, both of these gentlemen have resources, and both of them are considering a move to a more densely populated area like New York or Chicago because they have nicer public transport systems. Many people don't have the resources to consider a move like that.
Right, so it can affect where people would live, yeah. Okay, does anyone from the panel want to say anything, or should we go to vote? All right, the voting panel is open. I see 11 votes taken. One more person we're waiting on. And let us know if there's any trouble with the voting software. That can sometimes occur. Okay, seeing results, most people said neutral. And then with some responses in disagree, strongly disagree, and agree. So this is the last question, right? It's inform overall judgments of overall long-term value for money. Please indicate your level of agreement with the following statements based on the relative effects of sonperadagine versus usual care. Next slide, please. Oh, sorry, this is not the last question. Or actually, maybe the last question that we take. The treatment is likely to produce substantial improvement in caregivers' quality of life and or ability to pursue their own education, work, and family life. So maybe most appropriate at this point to hear from the patients.
Can I ask of Todd and Julie, as you think about this and the age of the patients who get RP, and the changes in vision that we're seeing, what's your take on that? What would be the implications for caregivers and life goals and quality of life? When we were discussing this at one point, I felt like we didn't really have enough information, even as we were doing the report on this. I'd be very interested in your take.
Well, this is Julie here. I think about for, when it's diagnosed a little bit earlier in life, the impact on the parents. I think it can be all consuming, to really advocate on behalf of your child. But then, of course, as your any kind of care partner, family member, to think about some of that potential treatment lifting a little bit of the weight in the way that, I think just making sure the basic needs of a family member or loved one is met on a daily basis. If that can be lifted a little bit, that they can then, focus on other things. I mean, I think that could certainly be a benefit.
This is Todd Durham. Yeah, I agree. the folks that I know with advanced RP, they come to rely on the family member or partner spouse very much for many things, many activities of daily living. I'm thinking of a former colleague who had bare light perception only. I remember the first time he told me how that he was getting meals from a charitable organization because, of course, it's impossible for him to prepare his own meals. And yeah, the meals are okay, is what he told me. So I'm just thinking about if there were just the ability to prepare a simple sandwich for yourself, could be a huge lift off a caregiver. And we hear these folks, they feel guilty about reliance on caregivers also. So they would love to have just a slight bit more independence.
Thank you. Does anyone else want to say anything in terms of informing this vote, or anyone from the panel want to make a comment about why they are going to vote the way they intend to vote? All right, with nothing more to say, let's move ahead to vote. You have 5 options on this question number 4. We have 6 votes in, 9 votes, 10, 11, one more, 12 votes. Okay, so most people said agree this treatment is likely to produce substantial improvements in caregivers' quality of life or ability to pursue their own education, work, and family life. And we've heard lots about that during the conversation, so I think it's pretty straightforward. I also just wanted to take a moment to announce on question 2, there was one individual on the panel who just clicked the wrong thing. And so we're switching a strongly disagree vote on question number 2 to strongly agree. It was just a mistake. With that, let's move on to question 5. So question 5 is, the treatment offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or method of delivery. So maybe Anil, do you want to first comment on that? We'll hear from the patients as well. Patient experts.
Yeah, so we heard a lot about potential changes to access to therapy with a gene therapy. Obviously, it's has to be accessed by seeing a specialist. I think we'll have these discussions in the policy roundtable, but whether that's going to be accessible in your regular ophthalmologist clinic, or do you have to see a retinal specialist, will be a ripe discussion. But we also heard the usual care of visual rehabilitation sometimes can require specialized training that isn't available geographically, and you have to travel. So certainly, if there is a treatment within the healthcare system that's covered by insurance, that potentially has some implications on access if it's affordable and available. And I should also add, the usual care is not covered within the healthcare system and by insurance, so those are borne typically out of pocket cost. And I would love to hear the perspectives of Julie and Todd on, as well as clinicians, on thoughts on access to care.
Yeah, exactly. Does anyone want to say something? I mean, obviously part of the issue of these questions is that we all have different thresholds to interpret different things, and that's the normal way. I tend to think of this question at getting at if there's intravenous therapy, say, for a treatment, and then all of a sudden maybe there's multiple options of intravenous, and then all of a sudden there's an oral option, which may really sort of democratize or broaden access to what had been more limited. This is obviously a different situation where there's not really an existing disease-specific therapy yet. Dr. Mahajan, do you want to make a comment?
Yeah, I'll make a quick comment. I think that's a very good analogy. So we've heard that if you do have access to lots of caregivers and these resources, that it does make a positive difference, obviously. But I have a large patient population that doesn't have access to those kinds of resources. As Todd mentioned, they can't move to a location where they can function better. And so it's almost a therapy like this that would actually, free them in a certain way. And so that's why access to this type of therapy, I think, is quite important. And as I think you mentioned that, a lot of those resources of vision rehabilitation and training are paid out of pocket, which a lot of people can't afford. And even if they have access, they can't pay for those, and those are also ongoing. It's like you have to do that repeatedly for things.
Yeah, no, it's a great.
So usual care that we've used to benchmark, I would say, is often less than usual care for a significant group of this population.
The implication is that this could actually improve access to care in a sense.
Yes, I mean it's almost replacing that. I think in many cases going beyond, but usual care is almost non-existent for a lot of people.
Yeah. Does anyone else, or Julie, do you want to go ahead? I think you're off mic.
Yes.
Okay.
Just a clarifying question. So this treatment would be delivered in the clinic, in their healthcare home. Would transportation be provided as part of the study? The reason I ask is I think that that's a big part of, what's unique about this population is that a lot of times they're, especially in sort of the main, regular healthcare domain, appointment times can be, they are what they are, right? But if you're using certain public transportation or like PACE or, certain services that you're connected with, there may be a delay. Maybe they're dropping off another patient before they get to the clinic where, you're going. And so what I've heard a lot is like the need to be flexible with the appointment times, that there's they're obviously not driving if they don't have access to somebody that can drive them to their appointments. It's a factor. And so while I love that it's provided in the healthcare setting, I mean it's always better if it can be provided under one roof, in my opinion, from what I hear from patients too. But to, I think, an added layer of accessibility for this population is the transportation accessibility component.
Julia, let me just chime in to say I'm going to pick up that thread in the policy roundtable. I really appreciate you raising that in terms of the continuity and the continuum of care for these patients. Thank you.
Hey, thank you, Sarah. It's an important point, and we look forward to the conversation. Unless anyone else wants to say anything, let's move to vote. So this is question 5, and the voting software is open. So I see 6 votes, 8 votes, 12 votes, and the most common was, we just moved, but the most common was agree with 6 votes, that the mechanism offers an opportunity to improve access to effective treatment. So the last question that we would have taken is the long-term value for money question, as far as, unless there was a price available in the last 50 minutes and no one told me since lunch, we will not be taking a vote on that last question. So we are actually slightly ahead of schedule. So let me, we have what would have been a 10-minute break. Sarah, do you have a preference for whether we pull people back 10 minutes early versus take a full break until 2?
Jason, Maddie asked us to stick with the 2 o'clock time.
Okay, all right. So you have a longer break than we anticipated because of excellent time management, I'll say. And we will see you all at 2 p.m. Thank you. 2 p.m. Eastern. I know people are different time zones. Thank you.